I don't know if Dr. Fahim joined us yet.
Can you see my screen?
Yeah.
Okay, that's fine.
We'll wait maybe 5 minutes. Maybe
Sorry,
other
say again?
can we wait 5 minutes other to give a chance other to join?
Yeah, sure, no problem.
Right.
Right. So how are you doing? You okay?
Alhamdulillah, yeah.
Excellent.
Everything going perfect.
So how many participants you are expecting today?
Well, 30 maybe 20 to 30 because the majority asked for the record as they still like some have work, some have lectures. They asked to delay it. I said, unfortunately, we can't. Like Dr. Ali can. It's hardly to push it to afternoon. And they will join. Some will join through the YouTube live, which is now streamed connected with YouTube, and some will come late to see the record.
Okay, whenever we can always look into the time without any problem next time if you feel like changing the time or something.
It will be perfect. Yeah.
Yeah.
When will be suitable for the next session?
If you will it be next Saturday or some other day you think?
Or next Saturday will be okay. We can fix it for now. Yeah.
So
But
what time basically suits
Hello.
Can we make it like
Hello,
9 p.m. Iraq time? So we'll be making 6 p.m. UK time.
Yeah, that's fine for me, Miss. Even I can do in the morning if you feel like, Miss. I can adjust my
No,
schedule.
they have problem with morning. They have problem with mornings. For them, like evening, much better. And when it will be like 6 p.m. UK time, so 9 p.m. Iraq time will be much like suitable for the majority.
All right, that's fine, Miss. Yeah, 6 p.m. should be okay. 6 p.m. UK time or GMT time, whatever you say, should be fine for me. Yeah.
Inshallah.
So because this is like a hands-on sort of training for junior physicians and the A&E physicians, basically very minimal what you call the pathophysiology. Basically, I will show them as much ECG as possible, and to help them pattern recognition. So that's what the aim is, uh, not the physiology or pathology of the ECG or any cardiac problems. It's just the ECG basically.
Yeah, inshallah.
So inshallah, yeah. Hopefully, if you feel like I can do it at 6 p.m. as well without any problem.
Great, inshallah. Dr. Ali will not open video, yeah? Will not
Sorry,
see
say
you.
again? Oh,
We
you
will
can't
not.
see me. Okay, sorry. I will do it now. Yeah.
Yeah.
Actually, I'm not very good in these sort of things. I'm sorry about that.
It's okay. It's okay.
When I do in hospital, the girls usually sort it for me. So at home,
MashaAllah.
can you see me now?
Yeah.
Hi. That's very good. Yeah, sure. So whenever you are ready, let me know and I will start here.
So I think now we have 48 joined yet. So I think we can start. Bismillah.
Okay. Bismillahirrahmanirrahim. Salamun alaikum to all of you. And thank you very much for having me here for today's talk. And of course, as I was talking to Dr. Abdullah, we are going to do this hand-on ECG session. It will be like series of lectures, comprises of almost 3 90-minute sessions. And basically what we are going to do today is we are going to show you as much ECGs as possible, basically help you understand and recognize the patterns of different ECG complication, including the rhythm step issues. And hopefully you will learn a lot, but it will be it will be having very minimal uh, physiology or pathophysiology of different ECG complications. So we are going to discuss very minimal, but I will show you as much ECG as possible. And hopefully that will help you in your acute management of the patient as well as during the ward rounds. And please feel free to interrupt me if at any stage you guys want some explanation of something. But because as mentioned, I have at almost 200 slides to show you in 3 days time. So I will not rush, but I will be explaining to you very briefly and keep showing you the patterns and different ECGs of same presentation so that you know how various aspects of the one problem can be seen in ECG. So let's start from the beginning.
So
So,
it's disturbed, Dr. Ali, that your camera is disturbed. I don't see you again.
oh, is it? Okay, let me sort it quickly. Is
Yeah,
it is
perfect, perfect.
all right? Sorry about that.
Yeah.
So okay, so let's start from the beginning. So I think there is some problem. It's not moving. Yeah, you're right. Yeah, so let's start with the normal conduction system of the heart. As you are all aware, ECG basically is a record of electrical activity of the heart, and electrical activity of heart is conducted through a very specialized tissue called conducting tissue in the heart. It comprises of sinoatrial node, AV node, bundle of his, then bundle branches, and Purkinje fibers. So the SA node is sitting on top of the right atrium. It's a very specialized electrical tissue which initiate and generate the electrical activity of the heart at the top of the right atrium. Then it conducts through three different tracks within the atrium called track of Buchanan, Welkebach, and Thorel. These are the three tracks through which the electrical is spread through the both atrium, and then from the SA node through this track, the current reaches the AV node, and AV node is sitting just on top of the atrioventricular septum, which is a fibrous band separating the atrium from the ventricles, and basically is non-conducting tissue and doesn't allow any current to pass from atrium to ventricles. So the only port of entry of current passing through from the atrium to the ventricle is the AV node, unless there are some accessory connections which we can discuss later. So from the AV node, the current travels into the interventricular septum, where the specialized tissue bundle of His is there, which just underneath the AV septum divides into two branches, the right bundle and the left bundle. So these are the two branches of the bundle of his, the right bundle branch and the left bundle branch. And left bundle branch are not, they subdivide into two, the left anterior hemifascicle and left posterior hemifascicle. And these two fascicles and the right bundle, they facilitate the transfer of current from bundle of his into the myocardium of the both ventricles. Right. So if we go back to SA node, the SA node, as I mentioned, is the primary pacemaker of the heart. It basically beats at the rate of around 80 to 100 beat per minute, but can be as slow as 60, which is normal. And then when the current reaches the AV node, basically there is some delay in the conduction of the current, and the heart rate here will be around 40 to 60, around 60 beat per minute. And then bundle of phase is again from 30 to 60. And if the current is in the Purkinje fiber, it will be around 20 to 40. So this is the speed of the conduction through various conducting tissues of the heart. Right. So, as I mentioned, the SA node is the primary pacemaker. Heart rate we have mentioned. We have talked about all these things. And the figure is again, the picture is showing the same thing, SA node and AV node, the bundle of phase. So we have already discussed that in depth. So let's talk about the normal ECG. So as I mentioned, the ECG is the recording of the electrical activity of the heart. So the by convention, there are P, Q, R, S, and T. So P wave basically represent the depolarization or electrical discharging of the current in the in the atrium. The SA node discharges the electrical current, then is spread through the atrium and creating the P wave. Then the current travels from the atrium to the ventricle, and the ventricular depolarization or the ventricular electrical discharge starts. The first deflection by convention is usually negative and is called Q wave, which is downward deflection. Then the first upward deflection is called R wave by convention, and the second downward deflection is S wave, then ST segment, and T wave. So when you are going to see different ECG strips, not all the components of the QRS complex will be there. I will explain later. So P wave is the electrical depolarization in the atrium, and the PR interval is basically start of the atrial depolarization to the start of the ventricular depolarization, and it should be between point between 3 to 5 small squares of the ECG strip, which I will show later. This is not very clear in this one. And if we talk about the time duration, it will be 0.04 to zero point 0.2 second. Similarly, the QRS duration is usually two small squares or between or up to 0.4 to 0.10 second normally. And ST segment is basically the representing the resting phase of the heart where no electrical activity is going on and no electrical current can pass through the myometrium. And T wave is basically recharging of the ventricles or ventricular repolarization. So these are various types of the deflections in the ECG and various intervals. So this is again same thing, but in proper ECG strip. So if you talk about the one big square or large square, this is, if you see there are 1, 2, 3, 4, 5, and if we go vertically again, 5 small boxes. So one small box is zero in duration is 0.4 seconds. So 5 small squares or one large square will be zero point 0.2 second. And if we go vertically, then it will be 1 millimeter, 2 millimeters. So one is large square is 5 millimeters. So let's have a look on the PR interval. So PR interval, if you have a look here, this is 1, 2, 3, 4. So it comprises of 4 small squares. So it is 0.4 second into 4 will be 0.01 second. And the normal duration of the PR is up to 0.2 second or 5 small squares. And then let's have a look on the QRS complex. There is a tiny tiny Q wave, then tall R wave, then again S wave. So the QRS duration is 1 to 2 small squares, which is 0.8 second. And similarly, if we talk about the QT interval, which is from the start of the QRS complex till the end of T wave. And this is 1, 2, 3, 4, 5, 6, 7, 8, 9. So almost 30.36 seconds. This is the calculated QT interval, but we have to correct it by heart rate according to the heart rate. So we have to look into the R interval, which I will show you later. And we have to divide this calculated QT interval by square root of the RR interval, which we have collected. If by having a look on the ECG, the easiest way to calculate the QT interval during the ward round or acute setting is, instead of calculating, just have a look on the QT interval and RR intervals. If it is less than half of the RR interval, this is considered to be normal. Right. So this is the different QRS nomenclature which I was mentioning. You may see all the three components of the QRS. There will be tiny negative deflection, small q, then predominantly measured upper deflection, which is positive, is called R, then S. So this will be a typical, which we conventionally say, but not all the ECG strip may be showing that. It may show R, tall R and tiny s, so it will be RS. It may be having tiny r and tiny s, which is RS again. There will be only one negative deflection, which may be Q. Then there may be two positive peaks, RSR pattern. So there will be tiny r or big R in the beginning, then negative deflection, which is S, then second peak or tall deflection, which will be major R, and of course, S may or may not be there. Then there will be tiny r and deep S. Then there will be deep negative deflection, which we don't know whether it is Q or S. So we normally call it QS, as there is no R wave. And this is again another nomenclature, which is negative first deflection. So it will be Q wave and the tall R. So this is QR. And similarly, it is QR. The first deflection is Q because it is wide and deep. And of course, tall tar is there. Right. So let's talk about different leads which we place on the patients and which record electrical activity. So basically, when we talk about the limb leads, we connect 4 leads to the patient on both arms and on the leg, or sometimes we can put it on the thigh or on the pelvic area as well, both sides. And so 4 limb leads, basically when it is generated into the ECG, it will show 6 limb leads. And each limb lead looks at the heart from the different angle in a coronal section from top to bottom. So if you have a look on the R wave is basically sitting on the right shoulder of the patient and looking at the heart from right side. And but is positive electrode is sitting inside the heart. We will talk about that later. Then AVL is sitting on the left shoulder, and of course AVF is looking at the heart from the inferior surface or from the feet. And AVL is sitting on the left lateral side of the heart, the lead 2 and 3, and AVF is basically looking at the heart inferior surface. So these are various limb leads, which will, of course, we'll discuss in depth later. Similarly, the pericardial or chest leads, they are looking at the heart into the horizontal section. So the V1 is sitting just onto the right side of the sternum. V2 is again on the left side, and then subsequently various leads from V1 to V6. So V1 and V2, they are sitting just inferior, just on top of the interventricular septum. So these are sometimes called septal reed. Then V3 and V4, they are sitting on the anterior surface of the heart and depicting the changes in the anterior surface. Similarly, the lateral leads will be V5 and V6, looking at the lateral surface of the heart. And if we go back, so if you look here, so the AVL and lead 1, they are also facing the lateral surface of the heart. The lead 2, 3, and AVF are facing onto the inferior surface of the heart. So we'll discuss that in depth again. This is the pericardial leads we have just discussed. So this is the front view of the heart, which we normally see. So if you have a look, they see the heart from different aspects. And so if you have a look on the anterior portion or anterior surface of the heart, this is the anterior surface. And this is the inferior. And similarly, that is the lateral surface of the heart, which we have discussed in depth. So, yeah. So let's go through the various surfaces of the heart. So lateral will be 1 AVL, which I have mentioned before, and V5, V6. Inferior will be 2, 3, and AVF. Then anterior or anterior septal leads are V1, V2, V3, V4. So this basically depicts various aspects of the heart, and which indicating that which leads you are going to see to know the pathology in the ECGs of that particular surface. AVR, as I mentioned, is considered to be cavity leads, is positive electrode sitting inside the heart, so it doesn't indicate any particular surface of the heart. Right, so we have talked about various surfaces or walls of the heart. Now we just have a look on the ECG, confirming which side, which electrical leads are confirming the various aspects of the heart. So inferior lead, as we mentioned, it will be 2, 3, and AVF. Lateral leads 1, AVL, V5, and V6, and then this is V1, V2 anterior, sorry, septal, and V3, V4 are anterior septal. So basically these V1, V2, V3, V4, we call them anterior septal leads. So it will be too early, but I will just briefly mention there are some abnormalities in the ECG. If you have a look on the anterior septal leads or from V1, V2, V3, V4, V5 to V6, you can have a look. This is the isoelectric line. And if you see, there is Q waves in the V1 and ST segment is elevated. Similarly, in V2, there is very, very tiny negative deflection, perhaps Q wave is developing or in evolution, and there is ST segment elevation in the lead V2. Similarly, V3, again, ST segment elevation, V4 ST segment elevation, V5 ST segment elevation, and in V6, there is little or tiny elevation of the ST segment. So this is basically acute ST segment anterolateral myocardial infarction. And there are some reciprocal changes, which is ST segment depression in lead 2-3 AVF. So this is the reverse picture of the ST segment elevation in the inferior leads. If any of you have any question in between, just feel free to interrupt me. Right. So let's proceed further and talk about normal ECG. So we have discussed on various deflections of the ECG, different nomenclature of the QRS complex, the interval and durations. So if you see this 12 lead ECG, lead 1, basically there is R wave and almost similar duration of the S wave. Lead 2, predominantly R wave. Lead 3, R wave. AVR, as I mentioned, is a cavity lead. So current is always flowing in the opposite direction. That's why it's always record negative deflections, including in the P wave. So P, Q, RS all will be negative in AVR. Just please remember that. AVF is again upright. So majority of the limb leads or deflections, except for the AVR, are all upright, which is a pattern of the normal ECG. In V1, you can see tiny R wave, and then there is no Q wave, tiny R, and then deep S. Why it is like that in V1? If you go back and see, the V1 is sitting in front of the right ventricle. When the current travels from the AV node to bundle of His and then into the bundle branches, the first current traveling is from left to right into the right ventricle. Because the thickness of the myocardium in the right ventricle is thin relative to the left ventricle, so electrical voltage is very, very minimal. So current is very minimal current is traveling through the right ventricle. That's why you will find positive deflection, that is R wave, into the lead V1, while the major deflection is negative, that is S wave, and the reason is current is traveling away from the lead 1 toward the lateral surface of the heart. That's why there is tiny R and major negative deflection, which is S. Whenever the current is traveling, if the current is traveling towards a specific lead, there will be positive deflection. If the current is traveling away from the particular lead, there will be negative deflection. So that's why you will find tiny R in lead V1 and then negative deflection. And because from left, if from V1 toward the V6, after V2, mainly the other leads, V3, V4, V5, V6, they are all sitting on top of the left ventricle. So current is traveling there. And because of the thickness of the left ventricle myocardium, the current will travel more strongly. So from V1, you see the R wave is developing. There is still S wave. In V3, there is more prominent R wave. The S wave is tinier. It means the current is mainly traveling towards the leads. V4, similarly, you can see the major deflection is again R, and S wave is becoming more smaller. V5, V6, there is no S wave, indicating that major bulk of electrical current is traveling toward the lateral lead. So this is, for practical purposes, very nice example of a normal ECG. And as I mentioned, the lead AVR is going to be negative, including the P wave. Right. We have discussed everything, and we will just quickly remind. So limb leads usually upright or positive deflection, except for the AVR, which we have discussed, is always going to be negative unless there is some reasons for it. So AVR can be positive if the limb leads are wrongly placed. Instead of putting lead onto the left arm leads are put on the right and vice versa. Then it can give you a opposite picture showing AVR to be positive. It can be because of the dextrocardia when the heart is sitting on the right side of the chest. And of course, if the heart is on the other side, the ECG waves will be in the opposite direction. That will be AVR positive. It can be in the extreme extreme right axis deviation as well. So for practical purposes, almost always AVR is negative, while 1, 2, 3 AVR, AVL, 1, 2, 3 AVL, AVF. These 5 leads will show positive deflection. Right. So let's again talk about the chest leads. Oops. Sorry. Look like it's playing a bit. I don't know why. Right. Yeah, this is a very funny way of talking about the progression of the R wave in the lead V1, V2. This is created by one of my very good colleague. He's a cardiologist. He says that the professor is in the ward. He want to take the ward round with the interns and residents, but for some reason they are in a funny mood. They are not in a working mood. They want to just enjoy the day. So they are sitting outside on a wall, high up, and looking toward the professor in a funny way. And professor is just, he's helpless. He's thinking, oh my God, what is happening? So basically V1, V2, the boys are looking downwards. So V1, V2, all the deflection will be downwards. In V3, V4, it may be equiphasic. There will be R wave, but similarly, there will be S wave. So they will be they call equiphasic. And in V5, the professor looking upwards. So all the leads will be upwards. So V5, V6, basically positive deflection. V1, V2, the residents are looking down toward the professor. So it will be V1, V2 negative mainly. And V4, V3, V4, they are equiphasic. Right, so let's see another ECG. So if we will go through the leads one by one. So lead 1 made mainly positive deflection. There is P, QRS complex, then ST segment, and T wave. Similarly, V2 is almost same, V3 is almost same. AVR is all negative. AVL is again positive. AVF is all positive. So we have discussed that majority of the limb leads has to be positive unless there is some reason to be negative deflections. V1, V2, you can see tiny R waves, mainly negative deflection, so looking downwards. V3, V4, you can see there is R wave, there is S wave, so this is equiphasic RS. And then again in lead 4, there is tiny S persisting, V5, V6, they are upright. So this is basically called progressive progression of R wave in the chest leads. V1 is tiny R wave, V2 R wave has progressed slightly, V3 R wave is more prominent, V4 R is again progress more toward the positive deflection, and similarly V5, V6. So this is called progressive progression of the R wave in anterior chest leads. It has some clinical implication, which we discuss when we see other ECGs. Right. So how we are going to interpret an ECG in a systematic manner? So when we have a look on the ECG strip, first of all, what we have to do is to calculate the heart rate. It can be normal, which we mentioned, anything between 60 to 100 beat per minute. It can be faster heart rate. It can be slower heart rate. Faster maybe more than 100, slower maybe more than 60. Sorry. Yeah. The rhythm, as you are aware that the heart activity starts in the sinoatrial or SA node. So basically heart rhythm initiates in the SA node. So any rhythm which is regular having P wave is called sinus rhythm, or it can be irregular for various reasons, which we'll discuss later. We have to make sure that P wave is present, indicating that the activity started in the SA node. And usually the best is to see the P wave is either in the lead 2 or lead V1, because they are just sitting on top of the SA node. Then we have to calculate the PR inter, which we have discussed before. Then we have to have a look on the QRS complexes to see whether their duration is within the acceptable range, which is between 1 to 3 small squares, like 0.4 second to 0.12 second. How is the Q wave? Is it pathological Q wave or the tiny Q wave? Is there any evidence of bundle branch block? And is there any evidence of voltage criteria for the left ventricle hypertrophy? Then we have to look into the cardiac axis, whether it is normal or right axis or the left axis. Then ST segment, either it is a straight line which is isoelectric, or there is ST segment depression or elevation. Then we have to have a look on the T wave, whether it is normal, peaked, or inverted. So this is a systematic way of interpreting an ECG. And so you need to remember these steps so that you can assess the ECG according to the situation and patient's presentation. Right. So you have looked into the ECG, and now what is the indication for you to have the ECG done? How the patient presented? What was the age of the patient? What was the clinical presentation of the patient, whether it was because of the chest pain, he was having thumping of the heartbeat, palpitation, racing of the heart, any shortness of breath, dizziness, syncopal attacks, or loss of consciousness, whether patient was hemodynamically stable at the time of presentation, all the vitals, blood pressure, pulse, and oxygen saturations were normal. Clinically, when you examine the patient, is there any sign of poor peripheral perfusion? Patient is whether in heart failure. But what is the past medical history of the patient? Any any comorbidities like hypertension, ischemic heart disease, diabetes, or chronic kidney disease, or any systemic chronic illness? What medication patient is taking? And of course, if the ECG is normal and you are still worried about the patient, then repeating the ECG after some time is going to help, and it may depict some changes after certain interval, and it may help you reaching to the conclusion of the patient's problem. And if you have access to the previous ECG of the patient, then you can just compare and see if there are any time interval changes in the ECG. Right. So the first step was to calculate the heart rate. This is a very simple and methodical way of calculating the heart rate. It's called rule of 300. You have to look into the RR duration interval of the ECG. and then divide it by the number of boxes between the each QRS complex, and that is equal to heart rate. So if the number of box between the two adjacent R waves is 1, heart rate is going to be 300. If there are two boxes between the two R waves, is going to be 300 divided by 2, which will be 150. Similarly, 3 boxes 100, 4 boxes 75, and so on. Right. So let's calculate the heart rate in this particular ECG rhythm strip. If you have a look, these are the two adjacent R waves. So the number of square is 1, 2, 3, 4, 5, 6. So 6 divided by 300. So you can calculate yourself. You can see here 6 divided by 400 is 50. So heart rate here is 50 beats per minute. Right. So now this is the full ECG tracing, and here you can again calculate. So as I mentioned, the best is lead to calculate the heart rate or look into the rhythm of the ECG is to have a look on the lead 2. So this is the lead 2, and the RR interval between the two adjacent R waves is 1, 2, 1 and 2. So 2 is squares. So 2 squares divided by 300 is going to give you heart rate of 300. Of course, the heart rate is, you can see the heart rate is rhythm strip is very busy. So ECG is showing faster heart rate, and the heart rate here is 150 beat per minute. You can see the you can't see P wave in this ECG. It means the rhythm is not sinus, but the RR interval is very regular. Most likely it is atrial tachycardia, which we'll discuss later. Right. And we already discussed that. So in order to rhythm the regularity of the rhythm, you just need to see whether the RR intervals are at are regular or not. You can do that by mapping, by putting the, you take a piece of paper, put it here, and just put the marking on adjacent 3 RR, and then move it, and you can just see they are regular or not, or otherwise you can use a protractor and just see from there. So yeah, so you can use a caliper or marking on a paper or pen and then decide about this. And again, you have to use lead 2, which is facing the SA node, and that will be best indicator of whether the rhythm is regular or not. Right. So of course, this is regular sinus rhythm because P wave is there, followed by QRS complex. So let's have a look on the P waves now. So in order for the rhythm to be sinus, as I mentioned before, each QRS complex need to be preceded by a P wave. The P waves need to be of same conformation. The shape should be alike, and the PR interval should be same throughout. So this is all about P wave, which is denoting the electrical depolarization of the atrium. So P waves are there. They all look alike, and they are all occurring at a regular interval. It means PR interval is same, and one P wave is preceded by each QRS complexes. So this is the normal P waves with one P wave for every QRS complex, indicating that it is sinus rhythm. So I've already discussed how you are going to calculate the PR interval. Normal duration is from 0.12 to 0.2 second, indicating that it need to be between 3 small squares to up to 5 small squares. So 3 to 5 small boxes. Right. We have already discussed how we are going to calculate the QRS duration. So in this particular, the normal is between one small square to up to 3 small squares, or 0.4 second to 0.12 second. And in this particular ECG, I think this is 2 small squares, so it is 0.8 second. So rhythm summary, the rate is in around 90 to 95. Regular, normal, PR interval is 3 small squares. QRS duration is 2 small squares. So this is normal sinus rhythm. Right. Let's talk about the voltage criteria for the ventricular hypertrophy in the QRS complexes. By convention, you have to use the sum of either one of lead V1 or V2 or V5 or V6, and then sum, it should be more than sorry, more than 35 millimeters. As I mentioned before, the one large square has 5 millimeter height. So if you have a look here, this is the isoelectric line of the ST segment. So here, one box, 2, 3, 4. So basically, the R wave is 4 large box, means 4 into 5 is 20 millimeter. And here you see the S wave, which is almost 1, 2, 3, and 3. So 15, 8 plus 3, 18. So 20 plus 18 is 38. So this is basically meeting the voltage criteria for the left ventricle hypertrophy. So it will be sum of S wave from V1 or V2 and R wave in the lateral leads. And if you sum it up, if it is more than 35, it will be left ventricular hypertrophy. Right, so this is a 12 lead ECG. So if you have a look on the lead V6, so it is almost 1, 2, 3, 4. So 4 large squares means 20 millimeters. And if you have a look on the lead 2, very, very deep S wave, 1, 2, 3, 4, 5. 5 means 25 millimeters. So 25 plus 20 means 45. This is moderate to severe left ventricular hypertrophy. And if you can see, there is no progression of the R wave in the anterior chest leads. This S wave are almost not there. Perhaps there's a tiny R wave in lead V3, then V4, and the V6, V5 and V6 are normal. So most likely patient had anterior septal MI, that's why the R waves are not there. Basically, this is QS pattern, indicating old anterior septal myocardial infarction. So what is cardiac axis? Cardiac axis is basically indicating the direction of the electrical current into the myocardium of the heart. And when you want to calculate a cardiac axis, you have to look into limb leads and calculate a vector which indicate which direction the current is flowing. And it's a very tedious job. It's a very complicated process. You have to calculate and looking into which angle the limb leads are sitting. I will just tell you the very hand-on and simple way of looking into the axis rather than calculating, which will take 15 to 20 minutes, and it's beyond the scope of this meeting where we don't have that much time. So if you want to calculate the cardiac axis, if you want to have a look which direction the current is flowing, you just have to look onto the two limb leads, that is 1 and AVF. And we use a double thumb criteria to indicate how we look into the cardiac axis. So if the lead 1 and AVF both are upright, it will be normal axis or double thumb up. Lead 1 is positive, lead AVF is positive, and both thumbs are like that up. It is double thumb up sign or normal axis. If it is right axis deviation, the lead 1 will be negative, means the one thumb is downwards, and the AVF will be positive, indicating the AVF thumb is up. So basically the two thumbs are facing each other. This is left axis, right axis deviation. Lead 1 is negative, lead AVF is positive, and thumbs are facing each other. If it is left axis deviation, lead 1 will be positive, AVF will be negative, and basically the both thumbs are facing in opposite directions. So this is the very simple and easiest way of telling the cardiac axis or direction of the electrical current in the myocardium. So what are the causes of the left axis deviation? It can be normal. It can be because of the ischemic heart disease. It can be because of the left ventricle hypertrophy, because with left ventricle hypertrophy, the major bulk of the current is traveling into the left ventricle. So the axis will be left. It could be because of the blockage of the left bundle branch. It could be because patient is having pacemaker in situ and having pacemaker rhythm. It could be because of the WPW syndrome or Wolff-Parkinson-White syndrome, which I will show you few ECGs later. It could be because of the conduction defects. It can be because of the mechanical pressure on the hearts, for example, because of the pressure, because of the pushing away of the inferior surface of a heart due to pregnancy. Could be because of the ascites or emphysema of the lungs. Similarly, the right axis, it is usually normal in children to have a right axis deviation. It could be because of the right ventricular hypertrophy, can be because of the pulmonary embolism, could be because of the septal defects of the heart, or again ischemic heart disease. It could be because of the chronic pulmonary lung disease. It could be cor pulmonale or dextrocardia when this heart is sitting on the right side of the chest, thereby it will be right axis deviation. Right, we have discussed that double thumb up sign indicating normal axis. And this is the ECG which is showing that. So one is upright, AVL, the major deflection, there is tiny S wave, but sorry, I'm putting the wrong lead. So both 1 and AVF both are upright, indicating that the axis is normal axis. Right. Again, another ECG. Lead 1 is mainly upright, AVF is upright. So both are indicating that this is positive double thumb sign and normal axis. Right. So right axis deviation, lead B1 is negative, AVF is positive. So both the thumbs are facing each other. indicating right axis deviation. And this is the ECG. If you see the lead V1 having tiny r and deep S, indicating that the major deflection of the current in the lead V1 is negative and lead AVF is positive. So the thumbs are facing each other, right axis deviation. Against another ECG, lead V1 is having both R and S wave, but the S wave is more deeper compared to the R, indicating that the major deflection is negative, that is S wave. And in AVF, there's a tiny Q wave, negative deflection, but major bulk is the R wave, indicating that AVF is mainly upright. So lead V1 negative, lead AVF positive. So thumbs are facing each other, indicating right axis deviation. If you have a look on the anterior chest lead in this particular ECG, because it is showing something, so I thought I will just mention here. If you see, I mentioned in previously that lead V1 is usually going to be major negative deflection, tiny R wave, but deep S wave. But in this particular ECG, there is tall R wave. Again, similarly, in the V2, there is a tall R wave. So it is showing right ventricle hypertrophy, which we will perhaps discuss later if we find more ECGs. For practical purposes, this is right axis deviation, and most likely there is right ventricle hypertrophy. Right, another ECG, the S wave is basically no positive deflection, so this is QS in lead 1. In AVF, it is tall R wave, so this is right axis deviation. If you have a look on the rhythm strip, which is lead 2, you see irregular, the RR interval is quite irregular, and you can hardly see any P wave, indicating that this is not a sinus rhythm, because there is no P wave, and the RR interval is quite irregular. So this is atrial fibrillation, which we will discuss in next lecture.
Dr. Ali, can I use the permission you give us to interrupt you?
Yeah, sure.
Yeah, please. So one of the colleagues asked in the chat, she said, what are the benefits from determining the axis deviation, as they are not specific, so many can causes, as you mentioned already. So is there benefit from knowing that or determining which axis is that?
Yeah. When we will discuss about the changes in the ST segment in the myocardial infarction, we will discuss about that. If the left axis, it could be indicating the heart blocks as well. If the left axis deviation is associated with, for example, first degree heart block or the right bundle branch block, it called bifascicular block. And similarly, so when we discuss about the heart blocks, I will explain the significance of discussing about the axis. Axis has its own significance, but for practical purposes, if the ECG is showing typical, changes, then you don't consider it much often. But if you are if you are finding it difficult to interpret ECG, then the QRS, the cardiac axis become more significant, and then you have to look into the heart blocks, and I will discuss that later, perhaps in next, not today, but next week.
So as I understand that it helps us together with other change to be more specific for the
Exactly.
determining the thing. Yeah.
So in order for you to interpret the ECG more in depth, you need to know the cardiac axis to correlate together various ECG findings, and reach to a conclusion. As I mentioned, one of the most easiest example is to talk about the heart blocks, and we talk about the heart blocks, first degree heart block, second degree heart block, and then fascicular block. So if the RBBP is associated with the left axis deviation, for example, it will be bifascicular block,
Mhm.
indicating that patient may need pacemaker depending on how he is presenting. So we'll discuss that in depth again. All right.
Thank you.
Is that okay, or you need more?
No, perfect. Perfect answer.
All right, perfect.
Absolutely. Thank you.
Yeah, we just have another half an hour, and I just want to finish as much as I can today because in total I have almost 200 slides and we have to finish them in 3 days time. But
Sure.
feel free to interrupt me at any stage you like.
Okay. So you gave me the permission again.
Yeah, it's perfectly all right for me.
Okay. Thank
So
you.
I think then and there, and if anybody is having query and we clarify that on that particular moment, that is more better for them.
Okay. Great. Thank you.
So this is again another ECG, and if you see the lead one is positive, lead AVF is negative, indicating that the thumbs are, you know, facing opposite direction, indicating left axis deviation. And this is again one AVF, one is upright, AVF is downwards. So sorry, yeah, sorry, I mixed up. In this ECG, yeah, this is left axis deviation. This is again lead V1. Lead AVF is negative, lead 1 is positive. This is left axis deviation. In this ECG, lead 1 is upright, lead AVF is negative, again left axis deviation. And this is again, yeah, this is, if you see, there is tiny R in lead 1, deep S is, and indicating that the major bulk of the current is downwards, indicating the lead 1 is negative and lead AVF is positive. So this is right axis deviation. And in this ECG, lead 1 is upright, lead AVF is negative deflection, indicating left axis deviation. This is a very good ECG. If you have a look on the lead, where is lead 2? Lead 2. You can see the P waves here. And so each QRS complex is preceded by a P wave. And if you see the duration of the PR interval, so P starts here, the QRS starts here. So if you see, this is almost PR interval is almost 7 small squares, means 0.24 second. So this is prolonged PR interval, which we will discuss later. It is first degree heart block. If you have a look on the QRS complex is more than 3 small squares, indicating that the QRS complex is broader. And so for practical purposes, this is left bundle branch block with left axis deviation, and QRS complex is, sorry, the PR interval is prolonged. So basically, this is a very significant changes in the ECG. The patient is having left bundle branch block and first degree heart block, indicating trifascicular block, and this patient eventually will need a pacemaker, which we can discuss in the next ECG, because I will discuss the bundle branch block in depth later. So this is another ECG. Lead 1 is upright. Lead AVF is negative. So this is left axis deviation. The other ECGs changes are not very significant. Right. So let's talk about the bundle branch block. And I think after that, we will slowly and gradually call it a day for today. And then we will just continue next week. So bundle branch block, yeah, this is, I showed you one ECG which was left bundle branch block. So for any ECG strip to indicate that there is bundle branch block, you have to look into the QRS duration, the QRS interval. So as I mentioned earlier, the QRS, normal QRS interval is anything between one is small square to up to 3 small square. If it is more than 3 small square or more than 0.12 second, that is more than 3 small square, then this is indicating Bunter-Branch block. So for any type of Bunter-Branch block, whether it is right or left, the QRS duration has to be more than 3 small squares and the shape will be broad and bizarre. The R wave will be in the opposite direction to the major QRS deflection. For example, if the R wave is tall, the T wave will be in the opposite direction. So if the QRS complex is negative, having major negative deflection, the the T wave will be upright. So for any ECG to confirm Bunter-Branch block, the QRS duration will be more than 3 small squares. It will be bizarre shape. The T wave will be opposite to the major deflection of the QRS, which we will discuss later. So for RBBB, there will be tall R wave in V1. And of course, if there is tall R wave in V1, the T will be negative. In the lead V5, V6, you will see S wave, which I mentioned before. Normally, it is not persisting in the lateral leads. For left Bunter-Branch block, there will be QS pattern in the lead V1, V2, while in the right bundle, there will be R wave in the lead V1, V2. In the lateral leads, in the left Bunter-Branch block, the predominant QRS deflection will be upright, that is R wave, while in the right bundle, it will be S wave. So basically, right bundle of branch changes will be mirror image of the left bundle. So when you see the ECGs, you will appreciate it more better. Right. So right Bunter-Branch block may be present in patient having acute pulmonary embolism. It could be in patient with any chronic lung disease affecting the heart, like carpulmonale, COPD, and it can be because of the cardiomyopathies and various septal defects as well. But almost 25% of the normal patients may be having RBBB. Sorry?
No,
Yeah,
I
so
think by mistake. Sorry. So keep
no,
on.
carry on. If you want to ask something, just please go ahead.
No question. Just was mistake.
Acha, sorry. Yeah, so in almost up to 25% of the patient, the right bundle branch can be normal variant. So right bundle is not that significant, but left bundle branch block, whenever is there, is very pathological. So as I mentioned, the left bundle branch block is always showing some cardiac pathology, which is usually sinister. It could be because of the various type of cardiomyopathies. It could be long-standing uncontrolled hypertension. It could be because of the left ventricle outflow tract problem like aortic stenosis. It could be hypertrophic cardiomyopathy, again causing left ventricle outflow of obstruction. It could be because of the ischemic heart disease. Right. So this is an ECG which is showing, this is the normal ECG. If you see, the QRS duration is perfectly normal. There's a P wave followed by QRS complex. QRS PR interval is normal. QRS duration is normal. ST segment is isoelectric, normal T wave. So this is practically speaking, the top ECG is normal. The left one is, if you have a look, in the anterior chest leads from V1 to V6, you can see the major deflection in lead V1 is upright, and there is, while in normal ECG, there will be tiny R and deep S. So this is basically major deflection V1, V2 upright, while there is persistence of the S wave in V lead V5, V6. So this is right bundle branch block. Well, if you have a look on the left bundle, on the ECG on the right side, you can see the lead V1, there is deep S wave, and the T wave is in the opposite direction of the major QRS deflection. So deep S wave and the T wave is opposite. While in right bundle branch block, you see the major deflection is upright and the T wave is inverted. So this is the major differentiating criteria for right and left bundle branch. And of course, as I mentioned, persistence of the S wave in the lateral leads. In case of right bundle branch block, you can see there is S wave persisting, while in left bundle, you see major deflection is R wave, there is no S wave, and T wave is opposite direction. So this is the very classical differentiation point between the left bundle and the right bundle. And as I mentioned, the QRS need to be broad and bizarre. T wave will be in the opposite direction to the major QRS deflection. So this is the differentiating point between the left and right bundle branch block. Right. So let's have examples of different ECG. So I will now just concentrate on the chest leads, and we will ignore the limb leads for the time being. If there is any significant change, I will definitely mention that. So if you have a look on the lead V1, there is tiny R wave, then S wave, and then tall R wave. So basically this is RSR pattern, which is not necessarily present in all the patients with right bundle branch block, but it may or may not present. And if you see, the T wave is in the opposite direction to the major QRS deflection. So this is RSR pattern with major deflection upright in the lead V1, indicating this is right bundle branch block. And if you see, there is persistence of the S wave in lead V5, V6. So for practical purposes, this is right bundle branch block. You can calculate the heart rate if you want here. So there is 1, 2. So yeah, so 2 boxes divided by 300. So is it almost 100? It is less than 100. So sorry, less than 150. So heart rate is almost 150 here, 140, and you can see the P waves without any problem. So this is the R wave. This is the T wave. This is the T wave, and this is P. This is P. So this is sinus rhythm with right bundle branch block. So it is sinus tachycardia with right bundle branch block, and of course there may be various reasons for it. Most likely it could be an acute strain of the right side of the heart, maybe acute pulmonary embolism, but difficult to say. Right. This is again very, very beautiful ECG. If you have a look on the anterior chest leads, the major deflection in the lead V1 is negative, very deep S wave, which is prolonged, more than 3 small squares, and the T wave is in the opposite direction of the major QRS deflection. So negative QRS with upright T wave, indicating this is left bundle branch block, and there is no persistence of the S wave in lead V1, V2. Again, the major deflection in later leads is upright, T wave is in the opposite direction. So broad bizarre complexes with T wave in the opposite direction of the major QRS deflection. So this is left bundle branch block. the axis is perfectly normal. And of course, we have discussed the various causes of the left bundle branch block earlier. Right. So this is another ECG. Anybody want to comment for which sort of bundle bronch is this ECG is showing? If anybody want to, otherwise I will discuss. Anybody want to try?
I think
Okay.
many. So if no one, I will take a part, but I hope other will take a part. Take part.
Yeah.
So some start to write in the chat.
Yeah.
So three of the colleagues write run like the bundle branch
Yeah.
block, which is
Yeah. Very right.
yeah.
Sure. So if you see, this is slightly blurred ECG, but if you see, you can see the tiny R wave preceded by S wave and then tall R wave. So this is RSR with the T wave in the opposite direction. This is for practical purposes. This is right bundle branch block. And if you see the axis, the the axis is quite complex here. If you see the lead V1, lead 1, there is R wave, there is S wave, and lead AVF again, same picture, but the R wave is very small and there is major deflection is downward. So practical purposes, the axis is left axis and the right bundle branch block is there. So if the axis is left along with another bundle branch block, which is right bundle, so practically speaking, this is bifascicular block. Left axis deviation plus right bundle branch block indicate bifascicular block, meaning bundle left, one of the branches of the left bundle is also partially blocked. So this is basically bifascicular block having right bundle branch block associated with left axis deviation. Right. So this is another ECG, very beautiful, very, very clear indication of left bundle branch block. And of course, on the top, it is saying same thing as well. You can see P wave. So this is sinus rhythm and regular rhythm is regular sinus and broad basal complexes. All the features of the left bundle branch block. And the axis is again left axis. Of course, if it is left axis along with left bundle branch block, it goes with the left bundle branch block because both the anterior and posterior hemifascicles of the left bundle is blocked. So it doesn't signify anything else. But in case of right bundle with left axis, that has clinical significance. Right. So this is another example of RSR, and this is right axis deviation and P waves are there. So this is sinus rhythm. The axis is normal. So practically, axis again left, one in AVF. So this is right axis deviation with the presence of left axis deviation. Of course, we need to correlate clinically to decide what is happening here. Right. So this is another left bundle branch block. So you can see how the left bundle branch blocks are showing in different patients' ECG. And it's very interesting to note how they can differ from each other. Right. So this is the end of today's session. And I'm very happy to take few questions if anybody has any queries about anything. I was thinking that I will take more time, but for some reason in the previous session, which I did for students in Pakistan about 2 months ago, it took almost 95 minutes, but today we have finished this quicker. Any question, anything? Any comments? Dr. Abdullah, you want to comment something?
Yeah, let's open like the chance for the colleague if they want to comment anything.
Yeah.
So, please, if you have any question, uh,
Yeah, we have another 10-15 minutes. We can.
yeah. So our colleague Sama asked how the identifying of the plan can affect change the management plan in the ER.
Sorry, say again. I could not hear you nicely.
Identifying the branch block,
Yeah.
how it will affect the management in ER.
ER. All right. Okay. So, if, for example, if the patient has come with uh, presented with chest pain and shortness of breath, and you have done the ECG, the ECG is showing left bundle branch block. I just go back and show the ECGs of the left bundle branch block. So this is left bundle branch block, and patient is having chest pain, shortness of breath. You have organized the troponin test, but it has not come back yet, and you are not sure that what is happening. You just by chance you found out that there is another ECG sitting in patient medical record, and that was normal ECG. So this ECG with patient presentation and previous ECG was perfectly normal. The current ECG is showing left bundle branch block. When the bundle branch block, especially the left one, is there, you simply can't comment on the ST segment depression, ST segment elevation of depression. You see this in this particular ECG, ST segment looks elevated. This is the isoelectric line, and the S wave is going up to here. So if you compare with the isoelectric line here, the ST segment is elevated. But this is one of the feature of the bundle branch block. So in patient presenting with left bundle branch block, you will not appreciate the patient is having ST segment depression or elevation because of the blocked bundle of the left side. So for practical purposes, you have to treat this patient as acute myocardial infarction, and this patient definitely need to go into the cath lab for the stenting or whatever they want to do for him. So if the left bundle branch block is there with the acute presentation of acute coronary syndrome, you cannot appreciate any changes of the ST segment elevation or depression, and you have to treat this patient as acute myocardial infarction. Similarly, if the patient is presenting with the chest pain, shortness of breath, sinus tachycardia, having right bundle branch block, and you have done the troponin test, it has come back negative. You are waiting for the D-dimer test to come back, but the patient is quite short of breath. Patient is having right bundle branch blocked, sinus tachycardia, and saturations are low, and you have clearly ruled out acute coronary event. This means the patient is having some pathology affecting the lungs, and most probably it is acute pulmonary embolism, and you have to just treat the patient accordingly. Patient, you need to start the, what you call it, the anticoagulation as soon as possible and resuscitate the patient. So we will discuss as and when any clinical scenario she has in her mind, I can just mention about that. But this two clinical scenario came into mind right now.
Yeah, yeah. Great. There is another question from
Yeah,
our
sure.
colleague Fatima. First, she's thanking you a lot for your like amazing lecture and all the benefits she got. And her question: any book you suggest for newly graduated like physician that can be helpful for the start, but in practical points?
Sorry, I could not get you, Rusi. You can.
So first, she's thanking you a lot.
Yeah, no, so nice of you. Thank you very much
Yeah.
for that. Yeah.
The second, she asked any recommendation for a book for a newly graduated physician, like junior
Is it
physician.
for ECG or?
Yeah, yeah, for ECG, exactly. Yeah.
Yeah, there are lots of ECG books are available. There's one. Uh, uh, I read all these ECG books very long ago, maybe 25 years ago, so I can't recall the names. But there is one ECG machine, very short but very practical. It's again called Making Sense of ECG. This
Mhm.
is very practical book, very short, maybe 100 pages, a small book, like hardcore book, which is pocket size. And I think she will benefit from that. And there's one very typical, very like textbook of the ECG, which I can't recall the name, but next session I will definitely let her know about that. But for practical purposes, she can read ECG book called Making Sense of the ECG and ECG Made Easy.
Mhm.
ECG Made Easy is like almost 25 to 30 pages book, and very practical, but not enough for residents who are doing the medical
Yeah.
jobs.
Yeah.
But
Uh,
ECG, Making Sense of the ECG is a very good book.
yeah. By the way, she asked about the next session. Well, I don't know how she joined us. We have the medical journal in Facebook group called Medical Journal. We share this like advancement for all these sessions. The new coming session, we have still a few sessions with Dr. Ali, and also we had previously many sessions like
All
for
right, okay.
basics and advanced sessions. So she can't see the records, and also we have other like video with other specialties with cardiologists, with the pulmonologist for management of dyspnea in ER, management of chest pain in ER. So it will be clinical like sessions.
Excellent,
Will be
excellent.
announced. Yeah, I shared already the YouTube channel where I shared these videos. She can see some of the sessions, and also the new coming session, inshallah, will be announced. Telegram group, junior doctors in Facebook, medical journal. If you don't have any of those, just tell me that, please. Also, some colleagues recommended by and in the Telegram group, we share always ECG cases and discuss it. So it's
All right, okay.
yeah, use like to be useful, I think.
Yeah, I will be very happy to join that as well, because
It will
I
be
can
great.
comment on ECGs if any,
Will be great. I will send you the link, and inshallah, this will be great.
inshallah.
Inshallah.
Perfect. All right.
Uh,
Excellent.
Alhamdulillah. So, any question, guys, colleagues?
Right. So if there is no question, then we will restart this hand-on ECG session next Saturday on at 6 p.m. as you rightly mentioned to me.
Inshallah,
Is that all right?
6 p.m. UK time, 9 p.m.
Sorry, UK time. Yeah. Sorry.
Inshallah. Yeah, it's a lot of really confusing, especially for me. I'm living in Australia, so I'm plus 1 hour from UK, minus 2 hours from Iraq, and I have always to think in three times, like UK.
All right. Okay.
Yeah, Alhamdulillah.
Appreciate your efforts. Thank you very much for that. And I request all junior colleagues who joined the session today to pray for us in the holy places, because you are blessed with living in one of the most holy places for our faith, our religion, and pray for us that we also visit holy places sometime, inshallah.
Inshallah. Thanks a lot for you, Doctor. Inshallah, if you will plan the future, like plan to visit Iraq, especially Najaf, Karbala, Karwin, we will all be honored to like host you, to welcome you, to be your
So
host.
nice of you. So inshallah
Inshallah.
soon, when the pandemic is over, inshallah.
Maybe the next plan will be together with Dr. Dr. Fahim, inshallah.
Inshallah, inshallah. Yeah, sure.
Inshallah.
Excellent. So nice of you, and wish you all the best in your future plans. And inshallah, Allah bless you all with success in whatever plans you have. And any help we can do from here, we'll be very happy to look into that for you. So all the best and ma salama.
Fi amanillah. Thank you.